Hi, everyone. I'm Tuya Pal. Welcome to our January ICARE case conference. And I want to start by wishing everyone a very happy new year. Just as a side note, ICARE is now, we're in our 15th year. And again, you see some of the metrics there, but we again are very appreciative to all of our provider partners and our participants. Again, really quick, referral to ICARE is super easy, whether it's online or through prepaid postcard. The other thing I wanted to put in, encouragement for is these case conferences are for education and for our providers to get expert feedback. So again, feel free to submit cases that you'd like additional feedback on. Here are just some resources. As you already know, we have biannual newsletters. Website has a lot of resources, and we are pretty active on social media. And again, you can see that there are multiple posts that we put forth on a monthly basis. A plugin for the upcoming BRCA 2025 conference that is hosted by Dr. Will Fowkes. And again, it's one of my most favorite conferences. It happens every couple of years. The deadline for abstract submission for a poster is still open. It's due on January 13th, but if you want more information, here is the website. But again, really, really phenomenal conference. We are also still recruiting participants to pilot a board game. It's called Life with Hereditary Cancer. Really the brainchild of my colleague, Dr. Debbie Cragen. She and I are working on a UO1 project, but if you have participants that might be interested, here is the QR code as well as the website to participate in this opportunity. Again, various opportunities through ICARE. We have our impact study for which we are still recruiting, really focused on strategies to improve cancer risk management as well as family communication. We have a pilot study as well focused on variants of uncertain significance, and then genomic characterization of breast cancers across 5 of what we sometimes consider the main inherited breast cancer genes, BRCA1 and 2, PALB2, ATM, and CHEK2. Now, I know we have a lot of content to cover. I wanted to start off with an ATM-focused case of a participant that actually participated in this tumor genomics study, which I found kind of interesting. This is one that myself and my colleague, Dr. Sonia Reed, co-lead. So it's a 35-year-old who at age 27 had genetic testing. It was through BRCA plus, which was negative, and BRCA plus does not include ATM. It's the high penetrance breast cancer genes. Age 30, diagnosed with DCIS, treated with double mastectomy. Age 35, keep in mind, after a double mastectomy, diagnosed with stage 1 hormone receptor positive breast cancer in the contralateral breast that the DCIS was in, treated with surgery and radiation therapy, but then found subsequently to have a local recurrence post-surgery. The Oncotype score was very high. It was 39. And then you can see here the family history where mother had breast cancer at age 34, died at age 39. There is a grandmother with pancreatic cancer and an uncle with pancreatic cancer, and then the sister with melanoma. And so again, 2016 result was negative. The 2024 result, there was a pathogenic mutation in ATM that was identified. So what's interesting about this case, again, this was a stage 1 breast cancer, so typically there wouldn't be tumor sequencing, but this patient participated in our tumor genomics study through ICARE. And what was found here is that copy number gain of HER2 path report that we already had on file was HER2 negative. But this prompted subsequent FISH testing, which showed HER2 amplification. And my colleague, again, this wasn't a patient at Vanderbilt. However, my colleagues, Dr. Park, who's our cancer center director, as well as my colleague, Dr. Sonia Reed, kind of advised me, and then Dr. Park interfaced with the patient's permission with her oncologist. And again, that's how treatment was actually modified based on these results. So again, just a quick story to kind of highlight, sometimes research can be translated into patient care. I think Sonia is on the call. Sonia, if you want to chime in with anything, feel free. Mark, do you have any? Oh, our guest expert today is our well-known Dr. Marc Tischkowitz, but Mark, do you have any comments here?
No, I think I mean it's interesting what you've got there. I mean, typically these are ER positive tumors, and yeah, I mean I think it's interesting how you managed to take this another step forward, essentially.
Yeah, and I have a comment from Sonia. This is a great example on how treatment can be modified. So yes, agree with that. So again, we're still recruiting for this study. So if you do have patients with mutations in those genes and breast cancer, please consider telling them about ICARE. Now, the focus of our case conference today, we have a lot of exciting cases to discuss, but we, after, I don't even know, maybe a year and a half of work, our ACMG sponsored ATM practice resource was released in early December. And this was an effort that myself, Mark, and Catherine Sean worked closely with many of our worldwide colleagues on. And again, you see here the multiple people from across the world that worked closely with us on this effort. So it's my pleasure to have Dr. Marc Tischkowitz, who all of you probably already know, who is the head of genetics, the Department of Genetics, I believe, at Cambridge, and very well-known clinical cancer geneticist who will be doing just an overview of ATM heterozygotes and our paper, and then we will go through a number of cases that are, again, super interesting. Mark, take it away.
Thank you very much, Tuya. And great to have the opportunity to present these guidelines that have only just come out. And I thought the first slide just shows really that this is, we've done this. This is the third set that we've done. We've been working our way through these genes that people have, previously been struggling a bit with. So we started with CALB2, then CHEK2, and now ATM. And it is a real testimony to this excellent international working group, actually, that we have lots of discussions, often at anti-social hours, that are actually very constructive. So I'd like to now, are you going to advance the slides for me? Yeah, thank you. So in terms of history, well, ATM has actually been known about for a very long time, originally identified as a gene in ataxia telangiectasia, and the breast cancer risks were, this was back in before even BRCA1 and BRCA2 were well established. And that original paper actually showed a twofold increased risk back in 1987. So it was an epidemiological based study, and those risks have held firm over the last 35 odd years. So the gene discovered in 95, and then the risk estimates always, were really firmly established in the mid 2000s. So we've known about this gene for a long time, but that doesn't mean to say that it isn't quite problematic, as we're going to find out over the course of this session. So in terms of risk estimates, the most recent ones are from the case control studies, the 2 case control studies, large ones that were published in the New England Journal a few years ago now. One was the Bridges one was the more European one, and the Carriers one was the US one. And you can see that there's good concordance there actually between the two in terms of overall risk estimates and penetrance. And that's been consistently the case throughout the history of study of this gene. So those are sort of the point estimates, but actually if you then look at the variation in the gene, it is quite pronounced. And this was quite a well-known figure where one superimposed the polygenic risk scores onto the point estimates, and you can see how there is overlap between all the genes here. And at ATM, the range of ATM goes back all the way to general population risk, up to a few cases that are sort of just on the boundary with the lower estimates of BRCA1 and BRCA2, with the majority being just over in sort of the more moderate range, as we call it, essentially. So that just gives you a good example. So these are the the risk estimates numerically. So twofold risk of breast cancer, around about a 6% risk by 50 and 32% risk by age 80. There have been studies looking at other risks. I think the most interesting one is the pancreatic cancer one, which does actually seem to be quite high. I think the confidence intervals around these are still quite large, but ATM is emerging as an important pancreatic cancer gene. So you can see those risks are pretty significantly high for this gene. Ovarian cancer is more tenuous, and if there is an increased risk, it seems to be below the sort of threshold of actionability. Also with prostate cancer, I think there are still some issues about the actual confidence intervals around the risk estimates, although there is evidence that that ATM germline pathogenic variants do seem to be associated with aggressive disease. Limited evidence for male breast cancer. There probably is some risk, but given the lower penetrance of this gene, it's going to be even lower for male breast cancer, and therefore the signal will be quite hard to pick up. And also some mixed results for gastric cancer, potentially some increased risk. Contrast breast cancer is really interesting because both Carriers and Bridges studies, so again, these are the case control studies, they both showed that all the well-known breast cancer genes that we know about do have an increased risk of contractile breast cancer, with the exception of ATM, which doesn't seem to have an increased risk of contractile breast cancer in either study. And this has been the interest. I think this has been generated quite a lot of interest and speculation why this may be. One possible explanation is that ATM breast cancers are typically ER positive. So one could speculate that if a woman has an ER positive breast cancer and is then having endocrine therapy, that endocrine therapy has a very strong preventative effect in the ATM compared to BRCA1, BRCA2, PALB2. So that could be an explanation. But then CHEK2 breast cancers are also ER positive, and you don't see the same effect there. So whether that's the full explanation or whether there's something very specific about the way that ATM causes breast cancer that makes it particularly sensitive to endocrine therapy, or there's some other mechanism, or is this still small numbers and maybe there is an increased risk of contralateral breast cancer, but it hasn't been seen yet in these studies. So I think we don't really know at this point, but it's interesting that both of these studies showed were concordant in this when we're looking at contralateral breast cancer. One of the things that's important to remember is that there does seem to be a higher risk with certain missense variants. So the well-known one is the 72712G, which is actually reasonably common. This was first described as a high-risk gene quite a few years ago, and there has been some consistency in this over time, except it wasn't seen in the in the Bridges study, the most recent study. But I you know, it probably is, and I think there will be more data on this in due course. So it does seem likely that there is a higher risk for this gene compared to the compared to the other types of ATM variants. And this is very much specifically to a particular domain at the 3' end of the ATM gene as well. So coming on to the recommendations that we made. So importantly, we felt that it's important to individualize risk in women who have ATM pathogenic variants, and to use something like CAN-RISK, but be aware that CAN-RISK currently is not designed to incorporate risks that deviate from the typical truncating pathogenic variants. So you can't use CAN-RISK for the particularly high risk variants like the 72771. So that's always something important to it. So for those high risk variants, you at the moment there isn't an easy way of modeling or individualizing risk estimates, and that's something that the CAN-RISK team are working on, but we're not there yet with it. The other key points are that most women who have an ATM pathogenic variant will meet criteria for some form of advanced surveillance, but not for risk reducing surgery, essentially. And also those who have a breast cancer diagnosis, typically their risk of contralateral breast cancer wouldn't be increased, as I've just shown you with those two studies. So contralateral risk reducing mastectomy shouldn't really be routinely offered, particularly when endocrine therapy probably has quite a strong effect in these women. In terms of pancreatic cancer surveillance, this is something that there's quite a big difference of opinion internationally, and I think it's more accepted in the US to offer pancreatic cancer surveillance as part of routine clinical management. Certainly in the UK, this is not the current position, where we still feel that the evidence is insufficient, that it reduces mortality, that there is a mortality benefit, and we still run pancreatic surveillance as part of as a research study, not as standard of care. For prostate cancer, again, a bit of a difference of opinion about PSA screening. Note the word consider there. So we're not absolutely recommending it. This is something to, perhaps based on family history, for example. And I think that in the US, this starts a bit younger. In the UK, we would start out at 50. For ovarian cancer, there isn't evidence to support any preventative surgery. But clearly, if there's some family history, then that will influence management, particularly if there's some surgery planned. In terms of therapy, this was a study from a few years ago which showed that the ATM and CHEK2 genes are not, do not seem to have a response to PARP inhibitors, essentially. Whereas something like the PALB2 gene, pathogenic variants in breast cancer related to that does have a response to PARP, and I think that's quite important to remember. So ATM CHEK2 are working in a different pathway to PALB2, BRCA1, and BRCA2. And but interestingly, despite evidence of efficacy in patients with in this context, olaparib can be given as a monotherapy. I think this is again more of a US thing because it's FDA approved. So it can be given in the context of patients with metastatic castration-resistant prostate cancer. But I'd be rather skeptical about, based on the evidence that we have for breast cancer, I'd be rather skeptical about the utility of olaparib in this situation. And we don't have any evidence of clinical benefit for targeted therapies in other tumor types. So I think if you have a woman who has for example, breast cancer with an ATM pathogenic variant, they would just get standard of care. Typically they are ER positive, so they would be going down that route. Another important consideration is that radiotherapy as part of standard of care for breast cancer should not be avoided. For many years, there's always been some issues about this because of the biallelic when someone's got biallelic pathogenic variants in ATM, they have ataxia-telangiectasia, which is very radiosensitive. So there's always a concern about heterozygotes, and particularly in the 20 years ago, there were some studies showing that cell lines, heterozygous cell lines, may be more sensitive to radiation treatment. But this hasn't been borne out of any clinical evidence, and therefore, women with breast cancer with ATM germline pathogenic variants should receive standard of care treatment for their breast cancer. In terms of partner testing, as I've just mentioned, there is this. If a child inherits a pathogenic variant from both parents, then they will develop something called ataxia-telangiectasia, which is quite a very sort of nasty childhood onset recessive disorder, particularly affecting neurological, immunological, and also with a high cancer incidence. And this should be something to be discussed with patients. And partner testing may be offered. Again, there are some differences about according to which country one is in regarding that. In terms of because ATM pathogenic variants are not particularly uncommon, it is, and certainly CHEK2 is not uncommon. You may see double heterozygotes with this, and certainly if ATM is combined with, say, BRCA1 or BRCA2, the penetrance for the more penetrant genes will outweigh whatever occurs with ATM. So I think these situations are quite special situations and worth looking at on a sort of case-by-case basis. And again, this is something that where CANRISC will particularly be helpful. These are the NCCN guidelines, which Tuya has led on, and gives you an idea of the lifetime risks and the management for this. So typically, mammograms would be reasonable for age 40, and again, this could be tailored, depending on the lifetime risk, using something like CANRISC. In terms of what we do in the UK, the main differences would be, I think in terms of surveillance, it's fairly similar. Again, we wouldn't offer risk-reducing mastectomy routinely, but if there's a particularly high risk, then it can be considered, so 30% and above. I've already mentioned that for pancreatic cancer, we're quite divergent compared to the US there, because we would not offer that as part of routine clinical care. And there's no formal surveillance program for prostate cancer. We would consider it PSA from 50. In terms of partner testing, this would only really be offered if there was consanguinity in the family. So to summarize the recommendations, so breast cancer surveillance recommendations should be based on individualized risk assessments. Most women will meet the criteria for enhanced breast surveillance, and there will be some differences based on country-specific guidelines. Key point is that CANRISC is not currently designed to incorporate risks of these higher risk missense variants, and that women typically do not usually meet the threshold for bilateral risk-reducing mastectomy. But it can, but if there's a particularly strong family history and the risk estimates are sufficiently high, then it's something that can be discussed. And the similar situation applies to contralateral risk-reducing mastectomy. And pancreatic cancer surveillance considered, but ideally part of a clinical trial. Consider prostate cancer screening. No evidence to support risk-reducing nephrectomy. So, and this is all sort of standard of care essentially. So ATM heterozygotes should be referred for a discussion about cancer risk, should be offered appropriate genetic counselling, also discuss reproductive options. And we offered predictive testing should be done in the context of in terms of genetic counselling. And there's also this issue about we'll come back to this in the cases actually, but there is this issue of even women who have negative predictive tests, they may still be increased risk of breast cancer, sufficiently increased risk to offer additional surveillance. So again, this should be personalized using a tool like CanRisk. And genetic counseling should include biallelic inheritance. Finally, just in terms of where the areas of need. I mean, one of the things when we're doing these papers is we notice how many areas there are still uncertainties. And I think one area where ATM penetrance, will be really improved is by incorporating polygenic risk scores. It's clear that polygenic risk scores will have a much bigger effect on the moderate risk genes like ATM and CHEK2 compared to the higher risk genes like BRCA1 and BRCA2. Because the polygenic risk score could really influence the ATM risk and can really change clinical management. We also need better prospective collected clinical data. There's this whole remaining issue about contralateral breast cancer risk, so that needs we need some better evidence about that and whether it really is related to treatment effect. There's limited data on therapies, and also the risk for other cancers still needs better more data to really improve the accuracy of those estimates. I think that's it, isn't it? Yeah.
So there were some questions in the chat, some from our colleague, Dr. Gareth Evans, pointing out the Swift et al. Paper, the breast cancer risk was 6.8-fold. I think the Swift et al. Paper was the first paper that highlighted the increased risk from my recollection. Is that right, Mark?
I think so, yeah.
And again, noted the heterozygote relative risk was 6.8. Gareth, I don't know if you have any thoughts on why that's so divergent from what subsequent risk estimates have been. I think the original Swift paper was based on the parents of patients with AT.
Yeah, it's the mothers of ATM homozygotes. So I'm not sure. I think probably because the mothers were quite young, and therefore this wasn't equivalent to a lifetime relative risk. It was equivalent to probably a risk under 50. And we know that the relative risk under 50 will be higher than the overall risk if you look at all age groups. So it might be because it's looking at younger ages that it created a higher relative risk.
Okay, no, that makes sense. And then here, tamoxifen, great question. I mean, we don't have tamoxifen uptake even in BRCA carriers. I don't know that we have ATM specific data at this point, but it's one of those things.
Well, you'd think it would work really well because over 90% of the cancers are ER positive.
ER positive. Yep.
So you'd think it would work really well. Mark presented the contralateral data suggesting that possibly the contralateral risk might have disappeared because of endocrine therapy. So, I mean, certainly in the UK, we would consider, or depending upon the level of risk, we'd either consider or offer endocrine therapy, either tamoxifen premenopausally or an aromatase postmenopausally. And in fact, we've seen quite high rates. And I think the problem is with BRCA1 and 2 is the risks are so high that they think a small reduction isn't really going to help. And we see extremely low uptake in BRCA1 and 2, but we see quite good uptake in people at 30 to 40% risk. So I think it's something that really should be considered in ATM carriers.
Okay, no, that makes sense.
Do you have an idea why why it's ATM and only where we don't see that increased risk of contralateral breast cancer?
No, I mean, I think probably the contralateral risk isn't as high in ATM as it is in CHEK2. Why? I've no idea, because
Well,
presumably all the breast tissue must be the same, and the relative risk is not that different.
no.
I mean, it might be that the studies just aren't large enough to come
Yeah.
up with,
Yeah.
you know, completely robust estimates.
Yeah, one would think that we have enough ATM worldwide carriers that we could figure this out with data.
Yeah, I think you just need to combine lots of series, really, and maybe you get a better idea.
Yeah, no, that's a great thought. And then here, another question is hormonal contraceptive use contraindicated for women with a pathogenic variant in ATM? To the best of my knowledge, no.
No.
Similar to how we think of BRCA, where it's not contraindicated per se. How does PRS impact the 7272? I think it's 7172 related. Is there a particular phenotype associated with 7271? Phenotype, not that I'm aware of. PRS is a data-free zone because if you think about it, that single variant is not like we don't have a PRS score specific to that specific variant. So we don't know would be kind of the bottom line. There was a question about risk reducing mastectomy as well, I saw, with the 7271 ATM variant. In the UK, I think the guidelines do state that it is appropriate to manage similar to BRCA carriers, which would mean risk reducing mastectomy would be a consideration. I don't think we're as prescriptive in NCCN at this point, although we do call it out and say manage based on risks. Mark, I don't know if you have any other comments on
No,
that.
I think there's a little bit of nervousness because of the carriers and bridges studies didn't show an increased risk for that, for that variant. But there's more data coming out. So we'll have a better idea on that soon.
And then here is breast MRI screening recommended for ATM carriers who've already had breast cancer. Yeah, if they have at-risk breast tissue, currently I think it is, but that's a good point because we don't know what the contralateral breast cancer risks are based on carriers and bridges. It doesn't seem to be elevated. I think most of us are still continuing to do the high-risk MRIs, but that's a great question. Should we be? I don't know the answer to that. Mark, what are the recommendations in the UK?
It would depend a little bit on, I mean, we'd probably go for mammogram screening, and if there was dense breast, then use MRI, and it depends a little bit on the contralateral breast cancer risk, which we don't think is that high. So I don't think we tend to do less MRI surveillance than you do, and I don't think it's particularly indicated in this situation.
Yeah, no, I would rethink it. I agree with you. And then neuroendocrine pancreatic cancer and ATM. I am not aware of any data. Mark, are you?
There tends to be adenocarcinomas.
Okay. I'm going to go ahead and go on. We have a number of really interesting cases, and I want to get through at least 3 of them. So let me just move on to start the cases. But again, many thanks for all the questions. So here's another case that was seen in our practice. Original history. So we have the proband here, 59-year-old, diagnosed with ER positive, PR negative, HER2 positive breast cancer, treated with chemotherapy, bilateral mastectomy. And then she had genetic testing done. Obviously, she had ATM, finding breast cancer in paternal aunts and ovarian cancer in maternal aunts. So you see that in the family history. I'm going to try and zip through this. So here is the original result. The ATM, there was one variant that was suspected deleterious. This was back in late 2018. Another one that was a VUS. And with the updated pedigree in late 2024, there was a pancreatic cancer in a niece that had developed. Now, we got an updated genetic test report in mid-2024, where one of the variants got upgraded to the suspected deleterious became deleterious. The VUS was upgraded to a suspected deleterious. So this is one that I actually, Mark, you may not remember this, but I did run past you. I also reached out to Aaron Munt at Myriad to kind of get a sense of, well, what was going on. And this is, I'm just going to highlight what Aaron shared with me, which was super helpful. So there remains a question regarding association with ataxia telangiectasia when seen as a compound heterozygote with another pathogenic variant. This is the one I'm talking about that used to be a VUS that was then upgraded. And this is the pheno curve that Myriad uses to kind of show where is the family history going? Is there a higher risk of cancer based on a specific variant? So here's some other comments from Aaron. There are a few individuals like current patient that do not have classic features of ataxia telangiectasia. Uncertainty whether this could cause an atypical ataxia telangiectasia phenotype, which was rationale for indicating that the association with AT is uncertain at this time. That was indicated in that test report we got back. Despite uncertainty regarding AT risk, given the pheno data, decided to change the classification to suspected deleterious or likely pathogenic, especially given it is measuring cancer risk on this pheno curve. Now, we always go to ClinVar when we get these kinds of variants, and you can see here that there is like some disagreement. So conflicting classifications, there's one with likely pathogenic, 13 with uncertain significance, and then there's even a likely benign here. And I just pulled out some of the highlights. Sequence change replaces, highly conserved amino acid, large physiochemical difference between tyrosine and cysteine observed in individuals affected with prostate cancer, pancreatic cancer, a bunch of other cancers. Variant predicted as damaging by various models, including polyphen and SIFT. So again, in our patient, there were no obvious signs of ataxia telangiectasia, but I had reached out to Mark about this to see, did he have other ideas? So a measurement potentially of chromosomal radiosensitivity, ATM protein level, and ATM kinase activity with use of results in the ataxia telangiectasia service is something that I think is available in the UK. AFP level could be helpful, as well as measurement of various immunoglobulins. And just to highlight, this isn't the only variant like this where you get it in biallelic form and it doesn't cause ataxia telangiectasia. There's another one that's fairly common that Aaron has presented on and talked about in the past, Aaron Munt from Myriad, which is classified as likely pathogenic based on internal RNA analysis, fully penetrant splice defect with no full-length transcript produced by the mutant allele, has been seen in trans with another pathogenic variant in an adult with no obvious features of AT. And this really makes us reconsider the relationship between cancer risk and AT risk for different ATM variants, I think is kind of the bottom line. So it's more complex than, when we're talking about partner testing, we're kind of working on the assumption that all AT or ATM mutations in the biallelic form would result in ATM, which again, I think is under question at this point. I know Aaron is on the call. Aaron, if you have any comments, I know a lot of this is content that you have educated me on. Mark, I don't know if you have any other thoughts on this one.
There's just a comment in the chat. The variants are definitely in trans. Do we know that?
They were thought to be in trans. That's what was on the report. It wasn't confirmed because then I went back to look at the family history and there hadn't been extensive testing, but it was thought to be in trans. Basically.
I mean, the paradigm is certainly with other genes like BRCA2 is that if you're getting biallelic pathogenic variants, then you've got there's going to be a strong phenotype. In that situation, it's Fanconi. Here it should be ataxia-telangiectasia. And if you're not getting that phenotype, then you really have to question whether one of those variants is not actually pathogenic or very hypomorphic. But it normally the severity of these biallelic conditions for these genes is so severe that it does make one question the pathogenicity of one of those variants.
And per what Erin has seen, Erin, I see you're on the call, so do you want to just highlight some of this? Because I know a lot of this is your data.
Yes, thanks. I agree, I think, with what Mark just said, and we've had a lot of conversation about both of these variants. And this 6919, we actually still classify this as uncertain. There are, as you said, Tuya, it's a pretty common variant. And so we have a number of individuals. I mean, last we looked at it years ago, we had over 40 individuals that were either homozygous for this variant or compound het and did not, we didn't have sufficient histories for all of them, but we knew a good number of them did not have any features of AT, and we would expect most of them, almost all of them did not have classic AT. So we've had lots of discussion about what to do with these. We've upgraded one, as you can see, and kept one VUS. And they're tricky. We've seen the same thing, or the opposite, I should say, with Fanconi. As Mark mentioned, we sometimes will see variants that are associated with Fanconi, and we don't see the cancer risks because we expect them to be reduced penetrant. So this is a shift. And again, we've had lots of conversation with the one you just presented to as you mentioned, that I told you, we decided to go with likely pathogenic because was showing us that cancer risk. We thought we trust that cancer association and wanted that information out there.
Thank you, Erin. That's super helpful. And I'm just gonna back to the patient. So there was a discussion with gynecologic oncology. The patient was interested in exploring risk-reducing salpingo-oophorectomy, which is not something that we typically advise for ATM carriers. And again, per the note, there was a very thoughtful discussion. She has a family history of ovarian cancer, which can guide what she wants to do, and she remains interested in the risk-reducing bilateral salpingo-oophorectomy. It's already status post bilateral mastectomy, and in the US, she is eligible for pancreatic cancer screening, so it is something we have referred her for. But again, I thought this was an interesting case because most of us are used to thinking about, oh, you have two ATM mutations, that equates to getting ataxia-telangiectasia. But as we learn more about, variants that don't necessarily behave the same as the typical variants we know about, that paradigm could shift. The other thing, and this is outlined in our ATM paper, is when you have that high penetrance ATM mutation alongside, one of the truncating mutations, your phenotype is actually less severe. And that is published. We have a reference in there. So again, that shows that there definitely is some genotype-phenotype correlations that can be taken into account, because the mutation that's leading to a higher risk of breast cancer is actually leading to a less severe form of ataxia-telangiectasia. Mark, I don't know if you want to comment any further on that.
The only other comment is that even in the mild or atypical AT affected individuals we see, they're still very severely affected, so they will still have, ataxia, they will have cancers at a much younger age. So it's a very strong phenotype, even when you have, one, as you said, the combination of truncating and missense. It's just that they're not, the classic ones are dying in childhood or early adulthood. These ones might, still be alive in their 40s, but they're quite debilitated by the condition.
Yes. And so here's another, this is an excellent question, which I don't know the answer to. What about radiation exposure or risk toxicity in biallelic ATM carriers, specifically the one we just discussed? And in my view, it's a data-free zone, but I would think that there should be hesitation, I would think, right? With
Well, certainly if they're clinically effective with AT, then yes, it's you want to avoid radiation or have them
no,
very,
but Mark,
very.
I'm talking about this
And
case.
these ones, I don't know.
I don't know the answer to that. Like, I don't even
Yeah.
know where to go
I mean,
with
did she have treatment for her? Did she have radiation treatment for her breast cancer?
this one. I don't think she did.
Because that would give you the
I don't-
answer. Often,
Yeah, that would
often
give
they,
us
often
an
they,
answer. I'll have to look
yeah.
back.
yeah.
Okay, but that is a great question. Okay, now we're going to go on to our next case. Again, a super interesting case. 32-year-old female, previously had genetic testing through her OB-GYN, through Natera, identified to have a pathogenic variant in the ATM gene. So it's an intronic variant. And then subsequently, Ambry testing was done. And the reason for that was to, like, Ambry will do additional testing through RNA to kind of clarify findings sometimes. And this same variant was found, but classified as a VUS. So here we have our classic discrepant findings, but in the same patient. So again, here is the ClinVar entry, where you can see likely pathogenic according to 4 entries and VUS for 2 entries. I also ran this past, so the first entry was an entry from the University of Washington by my colleague, Brian Schertz, who led this paper, who is now at Vanderbilt. So I went to Brian to ask him about this finding. So his comment, and I'm summarizing here, interesting variant. All the likely pathogenic calls are relying on RNA analysis. So RNA data from Sylvia Cassiday's paper, most of the transcripts from this allele are altered, but it looks like there is some residual full-length transcript. How do we, and then he posed the question, how do we correlate transcript levels with risk levels? And relationship is most likely not linear, and it's hard to predict the consequences of this variant. He also thought VUS classification was understandable based on, these discrepant findings, even though University of Washington, they classified it as likely pathogenic. And again, bottom line, variant is likely to have some additional cancer risks, but the risk may not be as high as clear loss of function variants. And bottom line, again, unclear how to incorporate this information for cancer risk management. Any thoughts, Mark? This is, again, another complex one. And I think, some of the reasons for highlighting these cases is, we always think of, okay, ATM, moderate penetrance in general, 20 to 30% lifetime risk. And sometimes it's not as clear as that. And, we're starting to see that with BRCA mutations where we have hypomorphic variants. So maybe we have that with ATM as well. So again, I do think risk assessment, as we learn more, could get more complex.
I mean, this could be a variant that's pathogenic, but not clinically useful. If it's falling below the if it's just increasing the risk by 1.5-fold, for example.
Yeah, so it could be like a hypomorphic one, right?
Yes,
So we
yeah.
just don't know enough at
No,
this point. So again, I thought that was an interesting one. Here's the next case. 42-year-old unaffected female right here, with a family history of breast and ovarian cancer, so breast cancer and ovarian cancer. Had genetic testing, was ATM positive, and this is the variant she had, C6976 minus 2A to C. Mother has not yet been tested, but my initial thought was this could be useful to refine risk, but we'll go into the CAN risk estimates to kind of show the various scenarios. So really management, we recommended high-risk breast screening. And then I'm going to go on to start the CAN-risk estimates that I generated and then hand it over to Marc to take it away and explain it some more. So the way I did it initially was mother, this is a real scenario, mother with unknown risks, right? And we reach about 30%, or 27.2. Mother being positive, we reach a risk of 26.3 lifetime risk. I'm just summarizing, but you see here the 5 and 10-year risks as well. And then when mother is negative, we reach a risk of 28.8%. So again, these confuse me. Whenever CAN-risk confuses me, I go directly to Marc. So I'm going to let Marc explain how this makes sense.
I think the first thing is that it makes very little difference. And then, you know, and in terms of probably the confidence intervals of the estimates, you know, it's pretty much all the same. And that really just reflects the, you know, the low penetrance of this gene, in essence. You know, that actually testing other family members isn't going to make that much difference to the risk of the individual. So, you know, so if the mother had the pathogenic variant, you know, CAN-risk slightly reduces the risk. If she doesn't, then it's slightly increased, because it's then factoring in that additional breast cancer from the mother onto the ATM risk. And if it's unknown, it sits exactly in between. You got the next slide. Yeah. So I mean, really, this just illustrates the limit.
So can I ask you one question,
sure,
though, Marc?
sure.
So this is a case for ATM, but the situation would be very different with CAN-risk if it was a high penetrance gene.
Well, this is what this slide is showing.
Okay, got it.
So this is a hypothetical scenario where you're testing a 20-year-old and the mother's got breast cancer at 50, and the mother's got, you know, carries a pathogenic variant in one of these different genes here, and you can see that the biggest reduction in risk for the individual would be if the mother had a BRCA1 or BRCA2 pathogenic variant. So it's the exact opposite of the penetrance of the gene. So the more penetrant the gene, the more impact the negative predictive test will have. And because ATM is not very penetrant, you know, actually it doesn't have, you know, the effect of this is not going to be very big. And that's exactly what we're seeing in your case.
Yeah, and you know what? This really highlights, again, this is so, in my mind, this is very clinically relevant, right? Because we're always talking to patients about refining risk estimates. So when we are talking to them about, okay, well, it would refine the risk more if your mother was tested. That's not necessarily true, right?
Not for these lower penetrance genes.
Not for those. It would be more for family significance in terms of, okay, well, that side of the family is at risk. So family communication, but from a risk refinement angle, not so much.
But what would make a difference here, you can see, is the polygenic risk score, if you add that in. So, for example, if you have a woman who's got a pathogenic variant and has a high PRS, you can see that makes a much bigger difference to her risk compared to the estimate in, you know, whatever happens to her mother. And equally, breast density also has a much bigger impact on risk compared to testing other relatives. So these are the areas where, you know, there could be a where the refinement of the risk will have the biggest effect, if you like. So PRS and breast density. And these are things that we're currently doing implementation studies for PRS. For breast density measurements, I think that's still logistically problematic, and I don't think people have really got a really easy solution to that at this point. But this just illustrates the effects that some of these other aspects can have. And then if you combine the hormonal and lifestyle factors as well, that these will all have some influence as well.
Yeah, no, which again is interesting. Like as we all get more comfortable, familiar with using CAN-risk, just knowing how to interpret it, because, you know, if we don't have this background necessarily.
No. Gareth, I think, has got a comment.
Yeah, it was just in relation to that it's sort of almost reflected when you test first degree relatives of a proband with breast cancer that have breast cancer themselves, the likelihood of that first-degree relative testing negative is least with BRCA1. It goes up to about 18–19% with BRCA2. It goes up to 50% with CHEK2. So it demonstrates that there is other things going on, polygenic things going on in that family that are increasing the likelihood of those that test negative developing breast cancer. So it's basically because the ATM or the CHEK2 does not account for all of the genetic risk in that family, and therefore there is additional genetic risk for those that test negative. And the phenocopy situation is exactly that. I mean, I described it many years ago for BRCA2, and as you saw from that the previous slide, the BRCA2 negative carrier is actually at moderate risk if they test negative because they have a first-degree relative diagnosed relatively young. And so Bodas here can risk has actually agreed with my papers from 20 or so years ago.
And that's a relief, Gareth.
Yeah, and here, this is a interesting question. Previously noted that we urgently need improved PRS scores for cases in which you are obtaining PRS. What lab are you using? Is this research-based only, or are there clinical labs you're comfortable with to ask for PRS scores? Again, I think this is well,
the important thing with the PRS is that in order to put it into CanRisk, it has to be a PRS that is already in CanRisk, or that you have an alpha for, so that you can, and you need a log odds. You can't put an ordinary odds ratio in. So it has to be a log odds, a Z score that you put in, but it has to be one that's already in there, or that an alpha has been calculated so you can put the alpha in. So it's not as straightforward as, you know, oh, I've got a readout from a company, I can just stick this in CanRisk. It needs to be put in as that specific PRS.
Yeah, I mean, this is a whole other discussion essentially, and you know, we can have discussions about standardization of PRS, ER positive PRSs, ER negative PRSs. So there's a lot to this. It's a simple question, but it's a complicated answer. But in the UK, we are running this currently in a NHS laboratory, so in a clinically accredited laboratory.
but are you using it
as part of an implementation study? So we're not using it as standard of practice, standard of care.
And I think
we're
that
still
would
learning
go-
about it.
Yeah, that's what it would go to here as well. We're still not at the point. Again, I think many of us know there are disparities in PRS across populations as well, like in terms of validation across populations. I know some of the labs have done a lot of great work to improve this. So I'm hopeful that we will be able to implement it into practice in the next few years. But again, I do worry when you get a PRS score of 40%. Are you going to act on it by doing a mastectomy? I don't know that any of us are comfortable with that yet.
No. And you need transparency from the companies about what exactly they've done and how they've calculated PRS. And Gareth makes an important point that you know, there are certain PRS. There are only certain PRSs that you can currently use in CanRisk, and there is a process in terms of adding new PRSs. So it is possible to add new PRSs, but there is a process to.
And, you know, the other thing I would say is if we are confident with PRSs, we like to enhance care, whether it be MRIs or risk-reducing mastectomies. We also need to be comfortable when the readout is lower to roll back care, because we can't just do it one way where we give more care, but we don't take away care. And I don't think anyone is comfortable doing that at this point. Yes, I think some of us will, like if PRS is kind of plopped in our laps and we have no choice, we may end up saying, okay, well, these are some other options for you. But I don't know that we're gonna roll back care yet.
Gareth has got his, I don't know if that's an old hand.
Oh,
Gareth
we
has
are
got
we
one
are
hand.
doing that in Manchester. And in fact, if you look at the latest paper from Boadicea CanRisk using UK Biobank data, PRS is actually more predictive of breast cancer than the CanRisk model itself, than the Boadicea model itself. It's actually a better predictor of developing breast cancer. And obviously within the model, it's even better. So I think we're far too reluctant in the genetics community to embrace the polygenic risk scores. They really are extremely good for breast cancer, and I'm trying to convert people because there is far too much reticence in the genetics community to using polygenic risk. We're so used to Mendelian genetics that we just can't grasp yet that polygenic risk has such a big effect, and it really does. I mean, you're not going to get to 40% risk with a polygenic risk alone. That's almost, 1 in 1,000 is going to get to 40% risk. They might get to 40% risk if they have other risk factors in CanRisk or in Tyrer-Cuzick or whichever model you use, but that would be extraordinarily rare to get to a 40% risk. So that's a sort of fourfold relative risk.
I think a lot of the reticence has also been due to different performance in different ethnic groups, and that's held the field back.
Well, the main issue is that the scores. I mean, the first thing is calibration. They're not calibrated for. There's a paper just out on European. It doesn't even calibrate the same across Europe. That if you're Greek, actually, the standard European PRS over predicts your risk. It still discriminates very well, but you have to calibrate the risk, the relative risk down based on ethnicity. So it really isn't as simple as, oh, you're a white Caucasian, we just stick this score on you. Actually, for someone who's Greek, you have to divide the score by sort of 1.15 to actually get the right relative risk. And it's a real problem. The real problem is in the Black community. Actually, East Asians, South Asians, it does discriminate, but you do need to recalibrate it, and that's the issue: is recalibration. But in the Black population, it really, a lot of the SNPs don't work, and there are additional SNPs that only work in the Black population, and you have to build a Black population PRS.
So Tuya, I think you need to invite Gareth to give one of your ICARE
I was thinking
that
you read my mind, Gareth. We'd love for you to give us a talk on PRS and present some cases, because you bring up great points. And again, you're right. The US is a much more litigious society than the UK, I would think. But that set aside, it would be important for all of us to kind of know what the data is and how we can push this, because I think all of us are very excited about the concept of PRS. Is just implementing it into the practice for the best care of our patients without missing anything is where our concern lies.
Yeah, I mean, I can understand why you'd be reluctant to withdraw screening when screening would be indicated without the PRS. And of course, the reality is all it is you're giving a likelihood of developing breast cancer. You're not, so obviously, even if the risk is extremely low, there will be some women who still develop breast cancer, and they might want to sue you because you've taken away screening they would have otherwise had if they hadn't had a low PRS. But I guess it's about, how confident you are that the company you've got the PRS from is reliable and the PRS is reliable. And it's then explaining that this is a likelihood. It is not, low does not mean zero.
Yeah. No, you're absolutely right. I see that we are over time. I apologize for that. Again, thank you everyone for attending. Gareth, especially, thank you so much for all of your insights. Much appreciated on behalf of
No
both myself
worries.
and Mark. As always, Mark, thank you for
Thank you, Mark.
Thank you.
co-hosting this case conference for the excellent presentation. We have some exciting upcoming presentations as well, or case conferences. In February, I have Dr. Fergus Couch presenting on BRCA2 missense variants. Some of the themes that we talked about today will carry forward with that, with continuum of risk. And then in March, I have Matt Urglin from Dana-Farber talking about colorectal cancer risk assessment. So again, please submit cases. It's an excellent way to get feedback. Here's our lineup for our upcoming case conferences, and we're adding more with time. So with that, I thank you for attending, and we will be in touch. Thank you.